So I think talks about guidelines tend to be pretty dry and boring. And so I'd like to kind of structure it around a case that may be a fairly typical case for who we see in practice. So this is a 65-year-old man. He's moderately obese, has mild chronic kidney disease, does not exercise, and has pre-diabetes. Atherosclerotic cardiovascular disease, 10-year calculator risk is 12%, so he's at moderately high risk for coronary disease events. And blood pressure is 148/88 at a clinic visit, which was appropriately checked 3 times, and it was in that range each time. And on a prior visit, it had also been over 140 systolic. So based on the evidence and good practice and the guidelines, here's some options. Have him buy a blood pressure cuff and take his blood pressure at home and record it at least once a week. Recommend exercise, weight loss, and dietary intervention. I know this will be covered by Dr. Chocklingham in much more detail, some of the treatment issues. Start 1 blood pressure medication now at this clinic visit based on his hypertension. Start 2 blood pressure medications now, for example, a calcium blocker and hydrochlorothiazide. Only start blood pressure medication if he remains hypertensive at a subsequent visit, or use as a goal to keep his systolic blood pressure less than 130. And I'll suggest that the guidelines support the following. Number 1, have him monitor his blood pressure at home. That helps in assuring that titration is effective, and it also may help with engagement and adherence. Recommend exercise, weight loss, and diet. And this is especially, it's important for the hypertension as a class 1 recommendation in the guidelines, but it's maybe even more important for pre-diabetes. You remember the diabetes prevention program showed a 60% reduction in development of diabetes with walking 30 minutes a day, 5 days a week, and modest weight control. And then starting 2 blood pressure medications is important if you want to get a 20 millimeter reduction in blood pressure, which is the goal with someone at high risk for coronary disease and a blood pressure approaching 150, then you really have to use 2 medications and might as well start out with 2 medications. And then the goal for him, according to both the European and the ACC AHA guidelines, is a goal blood pressure of less than 130 systolic. So I'll briefly go through these then. The burden of hypertension, I think, is clear. Large number of people and large number of deaths due to it, and it's common. In fact, for people age 65 without hypertension, 90% will eventually develop hypertension, and awareness and control is inadequate and relatively low. We have no shortage of guidelines. We have excellent guidelines that really review in a comprehensive way all the evidence around addressing the world's most important health problem. But they are somewhat different, and that's created some confusion, and they've changed over time. For example, the definition of hypertension has decreased over time, so more people, simply by a change in the definition, are classified as having hypertension. And then there was this nice review of the similarities and differences in the ESC and ACC AHA guidelines. And the main message here is the guidelines are actually very well aligned. And I'll stress the similarities, that they're comprehensive guidelines based on rigorous development processes. They emphasize accurate blood pressure measurements and the use of out-of-office readings as an important standard in the way we manage hypertension. They use cardiovascular risk estimation to inform decision about initiation. They have similar lifestyle recommendations for prevention and treatment of blood pressure. And they all recommend that we treat hypertension with medications if the blood pressure is at least 140 systolic or 90 diastolic after measuring the blood pressure carefully. There are some differences. There are lower systolic and diastolic blood pressure cut points for diagnosis in the ACC-AHA guideline, and the ACC-AHA guidelines recommend more aggressive treatment with respect to the targets and the initiation thresholds. So with respect to the ACC on top and the ESC below, again, hypertension is defined now in the American guidelines as 130 to 139 systolic, whereas that's high normal in the European guidelines. With respect to measurement, each of the guidelines recommends that there be repeated readings before diagnosing somebody with hypertension. ACC-AHA at least 2 readings on at least 2 occasions, and ESC 3 readings with averaging the 2 last blood pressure readings, and then each recommends confirmation of office blood pressure elevation with home blood pressure readings. With respect to the threshold, they're quite similar. Each recommends the 140 as the threshold for the total population, and then the 130 to 139 for those who have high cardiovascular risk and/or established cardiovascular disease, with the ACC-AHA guidelines being somewhat stronger in that latter category about initiating medication treatment. And then with respect to which treatments, again, this will be covered subsequently, but they're quite similar in terms of recommendation of the classes of drugs. So for this patient that I presented then, the European guidelines, this would be grade 1 hypertension, and because this patient's at high risk for cardiovascular disease, has some renal disease, the decision would be immediately initiating antihypertensive therapy. And then for the ACC-AHA guidelines, likewise, this would be stage 2 hypertension, and therefore blood pressure lowering medication should be started right away. In fact, even if this patient had a blood pressure of 130, according to the ACC-AHA guidelines, you should go ahead and start pharmacologic therapy right away, and then reassess the patient on a regular basis, at least within 1 month. With respect to the ESC blood pressure target description, it's targeting this 130 millimeters or lower, but not going less than 120. The ACC-AHA guidelines say it's okay to go less than 120 as long as people are asymptomatic, and both suggest going lower for the older population as long as the medication treatment is tolerated. But there is an elephant in the room, and that's that in spite of the guidelines and the evidence that we've got, that we're not doing such a good job in implementing effective control of blood pressure. And this takes a lot of education and encouragement of many patients who would rather not be treated with medications. And then there's the major challenge of medication adherence, which is a particular challenge in conditions like hypertension, where the treatments don't help symptoms because people aren't having symptoms from their hypertension. And we know that a large proportion of the population is not taking their medications on a regular basis. And addressing non-adherence in a systematic way then is really important. For example, if somebody's blood pressure is not controlled after you've started medications, to consider non-adherence as being a strong possibility about why that might be the case. Asking about whether patients are taking their medications, and being positive about approaching the issue of adherence in a way to prompts patients to be more adherent. And understanding why the patient is not adherent is so important. So the take-home points then from the various guidelines, and I've focused on the ESC and the ACC, AHA, is the guidelines are very well aligned. Treat patients with medications when the office blood pressure is greater than 140/90 or the home blood pressure is greater than 135/85. All patients should have lifestyle and behavioral counseling. Home monitoring is a key tool to help with patient engagement, adherence, and monitoring. And we have many effective treatments and more in development, but they will not help unless we're successful in having them used, adhered to, and titrated. Thanks for your attention.